Dr. Hitesh Garg is head of Ortho Spine Surgery Unit at Artemis Hospital, Gurugram, and he has a rich experience of more than 15 years in spine surgery and has worked at many apex institutes around the globe like Yale University. I will not take much time and invite him for today's talk.
Good evening everyone. First of all, I would like to thank the members of IMS South Delhi branch for giving us this opportunity to present our work here. I am Dr. Hitesh and I do all kinds of spine surgeries, but scoliosis is my passion. As Dr. Garewal was telling, one of my neighbors was actually suffering from scoliosis, and I went to AIMS with her, Dr. Jaiswal, and he just said that you are too late. And somehow that stuck in my mind, and I went on to do orthopedics and then spine surgery and then subspecialized in scoliosis surgery from Schneider's Hospital. And then I came back. When I was going to US, I was sitting in 40s and someone was telling me, you are mad, who does scoliosis in private practice? But when I came back, we started doing scoliosis surgery at Artemis in 2011, and till date we have finished around 1500 scoliosis surgeries. And this, as Dr. Garewal was telling, is right. It's a highly neglected disease. A lot of doctors don't know that yes, there is a treatment for this, and it is almost 99% successful with it's very safe these days if we catch scoliosis early. And so the topic is early detection of scoliosis today. So this is X-ray of a 15-year-old girl. She is the daughter of a plastic surgeon. Just because of the fear that she will get paralyzed, she was not operated. And look at how her spine is curved. So when I saw her first, she was very depressed. She didn't want to talk to anyone. She's just 15 years old. She was very sad. So of course, finally, because we had reached a point where it was affecting her lungs and she could not eat, so we started doing her surgery, and it was done over a period of 3 months, where we initially put her in halo traction for 6 weeks, then did the stage 1 where we break the spine in multiple points and did put multiple screws, and finally we corrected her spine, and she was a very happy and confident child when I first met her after 15 days of surgery.
Sir, we can't see.
Sorry, thank you. Sorry. So the purpose of showing this, of course, this is a very complex surgery because we treated her at a very advanced stage, and it took us almost 3 months to fully correct her. The purpose is that how to identify scoliosis early so that it does not reach at that advanced stage. So scoliosis is defined as any lateral curvature of the spine of more than 10 degrees. Normally the spine is straight, but actually it is not just the lateral curvature, the whole spine gets rotated. Now we know it's a 3-dimensional deformity. The whole thorax gets rotated in 3 dimensions. So this is how, so the ribs get pushed backward and leads to a big hump over the back, known as a rib hump or covert in our local language. So this is how a spine looks straight, but in scoliosis it's not just the lateral curvature, the whole spine gets curved, and initially it was being treated with Harrington rod thinking that it is just a lateral curvature. So nowadays we are using screws to derotate the spine in all the 3 planes. So how can we identify? We see patients day in and day out. So whenever we see that the shoulders are not level, or the pelvis is not level, or there is a rib hump on one side, all the pediatricians are actually requested to screen all the patients, that they should tell the patient to bend forward when they come for routine examination. And if they find that there is a rib hump, there is prominence on one side, that means this patient might be having scoliosis, and it should be referred to a spine specialist. So this is our normal spine, and this is when we tell the patient to forward. This is known as Adams forward bending test. So the spine on one side gets prominent. Now we have to catch scoliosis at early stage, like there is a photograph on the left side. Now anyone can identify scoliosis, even a layman can identify that this girl is having a problem as it is on the right side. As doctors we need to identify as it is on the left side. So whenever we find that this patient might be having scoliosis, we don't order just small X-ray, we have to order full length X-ray. We have to get full length X-ray on 3-feet film, and it is available a lot of places in Delhi. So it has to be full length X-ray on a 3-feet film in standing position. So do not order short film, that is just unnecessary radiation to the patient. And then the entire management of scoliosis is based on angle known as Cobb's angle. So we measure the angle along the most tilted vertebra in the curve, and that angle is known as Cobb's angle. Now scoliosis, the most common type of scoliosis is idiopathic scoliosis. Idiopathic means of unknown etiology, but now we know that it's genetic in origin. And most common age of presentation is when the kids are just entering their growth spurt in adolescence. So at around 10 to 12 years in girls and 12 to 14 in boys. Another kind of scoliosis is congenital scoliosis, which is by birth due to some insult in utero. So this is due to malformed vertebra. But congenital scoliosis is not genetic. It is not passed on. It is not determined by genes. It is due to some insult when the patient was pregnant. Mother was pregnant, and then there can be neuromuscular problems. Whenever there is a neuromuscular imbalance like poliomyelitis, it leads to scoliosis. And then there are syndromes, and finally degenerative scoliosis, which we get due to degeneration of disc in old age. So I will just run through some slides quickly. So idiopathic scoliosis, it is just for management. It is divided in infantile, juvenile, and adolescent. Because if we get scoliosis at a very young age, someone who is 0 to 3 years of age, it can progress very rapidly. So we need to brace them early. So as quickly as we can catch it early, the treatment can be very, very simple. Now progression, the most important thing is the scoliosis is seen in kids, and it progresses very rapidly when the kids enter their growth spurt. So to determine the growth, we look at the pelvis X-ray, we look at the research sign. For the girls, we ask the menarche. So just when they start the menses, that is when the girls are just entering the growth spurt, and that is a time when it progresses very, very rapidly. Or in males, whenever there is a certain size change in the size of the shoe, like they have increased foot size or they are increasing the height velocity. So this is as the growth velocity just before the adolescent, if you see here, just before the kids are entering their growth spurt, that is the time when the Cobb's angle gets worse all of a sudden. So why are we concerned about this scoliosis? Because we know that the scoliosis, it's not a cosmetic deformity, it's a medical disease. If we don't stop it early, this keeps on getting worse with time, and once the Cobb's angle reaches 80 degrees, it starts affecting our lungs, it starts affecting our breathing. And once it reaches 90 to 100 degrees, patients are unable to eat their food fully and they start losing weight. And after 120 degrees, it starts causing severe back pain, and then it can have neurological deficit. It actually is associated with reduced life expectancy. So as I was telling you, that the treatment is entirely based on Cobb's angle. So if the Cobb's angle is less than 25 degrees, we just observe them, because not all scoliosis progress. We intervene only when the scoliosis is getting worse. So we observe them by serial X-rays every 6 months. If the angle is more than 25 degrees but less than 40 degrees, and the research 0 to 2 means that the patient still is growing, then we give them a brace to control the scoliosis, so that we can modulate the growth pattern and we don't have to operate. Our aim is that the scoliosis should not reach 50 degrees. Once it reaches 50 degrees, it is recommended that we should always operate. The scoliosis does not cause any problems till it is 80 degrees. But we don't want to operate at 80 degrees because the surgery gets complex. We want to operate at 50 degrees because our long-term studies have proven, once the scoliosis crosses 45 to 50 degrees, even after the growth of the child has stopped, this scoliosis keeps on getting worse by 1 to 2 degrees every year. So suppose someone is having, say, 60 degree scoliosis, once a girl of 18 years old. So once she will reach 30 years old, this scoliosis will get to 80 degrees, and then it will start affecting her lungs. And 30, she is very young at 30 years of age. So there are like thousands of braces. We use Boston's brace most of the time. So surgery is done once the curve magnitude is greater than 50 degrees. Why? Because the natural history shows that these curves will progress 1 degree per year. Now what are the goals of surgery? Of course, the primary goal is to stop the progression of scoliosis. At 50 degrees, scoliosis does not cause any problem. If we just stop the scoliosis at that point of time, that is our medical goal is served. And at the end of the day, we want to achieve a balanced spine, that the shoulder should be level and the head should be centered over the pelvis. But since we have got such good instrumentation these days, and most of the patients come to us for cosmesis, they don't know about all these effects. So we correct the spine now in all 3 planes, giving a very good cosmetic result to the patient. So these are some of the cases, different types of curves. So nowadays we don't use Remington rods, we put screws in multiple vertebral bones, and we actually derotate the spine. We don't, there's very rarely we do thoracoplasty or cut the leg hump as it was being done around 15 years back. So nowadays, even in the sagittal, in the lateral profile, we are able to get a very good alignment. So this is how we put the screws and we put these attachments, and with these attachments, we using the lever arm, we de-rotate the whole spine and then de-rotate the individual vertebra in their original position and achieve a good correction. So these are some of the cases, different types of curves, how we get a good correction, giving a good cosmetic correction all to the patient. So this is one of the patients that did a demonstration surgery in Gwalior. So this patient was very poor. So in Guwahati I did this. So this patient was having almost 100 degrees of scoliosis, and this is how her X-rays were looking, and then this is how it looks in trop. So once we put screws and rods and we de-rotate the spine, and this is how he looks. So this is how he looks pre-op, and this is how he looks post-op. Look at, so these kids, once they get corrected, I mean, I can't tell you how satisfied they feel. The entire their confidence level in their classrooms, in their college, it changes entirely. So this is how this is the change that happens in these cases. Now infantile scoliosis, as I was telling you, once we catch scoliosis when the patient is very young, we do something known as Mehta casting. This was invented by Professor Mehta from India. She was not recognized here. She had to go to UK where she got the recognition, and I learned this in US. So if we get catch scoliosis early, someone who is having in 1 year old, we just with the casting, serial casting every 3 months or 2 months, we keep changing this cast and we can get a good result. So this is how the child was when the child came to me, and after 1 year just with casting without any surgery we could get a good correction. This is the last case I am presenting. This is a 5-year-old girl who came to me with a very large scoliosis, 120 degree scoliosis. Now this is the latest technology. We cannot leave this curve. At 5 years, the problem is I cannot make it, I cannot correct it and fuse it, because how the child will grow. We cannot fuse the spine before 8 years of age, because otherwise the lungs don't grow and the patient can get respiratory insufficiency. So it was a challenge. So now we have a technology known as magnetic growing rods. So what we did was we got these rods for her and we put these rods. So we don't open the spine in the middle. We just anchor the spine at the top, anchor the spine at the bottom. In the middle, we just slide these rods. These are magnetic rods, and every 2 to 3 months, these child come to us, and we put this magnet on the back, and there is a coil which rotates. So what we have done is with this is So what we have done is we have controlled the scoliosis. And then we changed to normal growing rods. So what we have done is we have not fused the spine. We just corrected the spine partially so that it does not get worse with time. And every 2 to 3 months we are expanding these rods so that as the child grows, the spine also keeps on growing. Now she is 8 years old and we have changed the magnetic growing rods because they were outgrown. At 8 years, for 3 years we kept on lengthening them. And now we have put these normal growing rods. The purpose of normal growing rods is because magnetic growing rods were very costly, so they could not afford another magnetic growing rods. Now in these growing rods, these every 6 months, so there are connectors there. So every 6 months we make a small opening here, but it's a surgery, and we open these screws and we lengthen the rods. So the rods keep sliding. So this we have to do every 6 months. This is surgical now. Now this girl is around 10 years old and I've been following her up for 5 years. And so this is where we started and this is how she is looking now. And once she is around 12 to 13 years old, we will do the final fusion surgery. We will correct her spine. So the congenital scoliosis where the vertebrae are malformed. So vertebrae are not formed normally. So one of the bones is has the vertebra on this side, it's formed half. This is not hemivertebra, so the spine keeps on growing on this side, does not grow on this side. So this also leads to scoliosis known as congenital scoliosis. They have multiple cranial or spinal cord anomalies. So this is some of the where we do a resection of this abnormal vertebra and we correct this spine. So we have corrected, there was a abnormal vertebra here. We removed this vertebra, replaced it with a cage and got a straight spine. This is how she was looking before and after. This is congenital scoliosis. Then there is a neuromuscular scoliosis which happens like in cases like Duchenne muscular dystrophy, spinal muscular atrophy, poliomyelitis, where due to muscle imbalance patients get scoliosis. Now these patients are mostly bedridden, but they are not able to sit straight, so they get a lot of sores and it's very difficult for the parents to take care of them. So if we correct their spine, they are able to sit straight and the taking care of these patients becomes very easy. They are able to sit much longer, they don't get all these bed sores and everything. Adult scoliosis happens in the adult age due to degeneration of the discs. This is also very, very common, very challenging, and so we are doing this where we have to correct this scoliosis. The more important in adult scoliosis is that we have to correct the lateral curvature. If you look at this X-ray, this patient is bending forward. It is the center of gravity is in front, so we have to bring it back and put the head over the pelvis in the lateral axis. The sagittal profile is very, very important in the degenerative scoliosis. So this we do in old age. Thank you.
So now I'll be introducing the second speaker, Dr. Varun Khanna. He is also working in Artemis Hospital, same with Dr. Hitesh Garg, and he has a vast experience in the field of orthopedics and spine surgery over last 10 years. He did his graduation from prestigious Medical College Kolkata and MS Orthopedics from GNC Amritsar. Subsequently, he completed his senior residency from Department of ESI, PGI, MER, New Delhi, followed by AIMS, New Delhi. So over to Dr. Varun Khanna.
It's a matter of great privilege for me to give this talk in front of this distinguished physician forum. So I'm Varun Khanna. I completed my fellowship in spine surgery, the FNB spine surgery, and right now working in Artemis Gurgaon and Artemis Light New Friends Colony. So in this talk we will have an overview about introduction to the low back pain, how to approach a patient with low back pain, and what are the common conditions that we see day in and day out in our OPDs, the lumbar disc collapse, the lumbar canal stenosis, and adult spondylolisthesis. So there is a statistic about low back pain that more than 80% of the population will experience an episode of low back pain at some point in their lives. Low back pain is highly prevalent globally and is the second most common cause of disability. So how to proceed when a patient of low back pain comes to our OPD? So how do we, what is the thought process that we should think so that we are able to crack the diagnosis? So first of all, foremost thing is that we have to check that is this pain actually arising from the spine? Are there any associated red flags? What is the pain syndrome? And what is the true physical disability in this patient? And then we go on to see the physical tests and the investigations. So, is the pain actually originating from the spine? We must see that not all back pains are from the spine. There are other causes like viscerogenic back pain, vascular back pain, or psychogenic back pain. So, in the spine pain mimics, there are certain viscerogenic kidney or retroperitoneal tumors which present as back pain, or there are vascular anomalies like aortic aneurysm which might present as back pain. So we must keep those things in mind. The second question that we should see is that whether the back pain is associated with any red flag. So the red flags are mainly the age, high age, if there is a history of trauma, if there is a history of malignancy, if there is night sweat, if there is any history of weight loss associated with back pain, if there is any fever, or if there is any bladder power involvement. So we have to see that there are any red flags associated with the back pain. The second thing that you see is that are there any yellow flags? These are namely the signs which will tell us that there is actual disability that the patient is facing. Because a lot of times the patient will come with the back pain and it does not match with our findings. So the findings are inconsistent. There is a normal pain behavior, patient is seeking bed rest or just trying to avoid a litigation, or there is work dissatisfaction and so on. There are other causes. So we categorize and we have to rule these causes so that we are knowing that there is actual physical disability. So what are the 4 tenets to diagnose low back pain. So in spine surgery, we say that 80% of the information we can get from just history, then followed by physical examination, and lastly the imaging. But we make a cardinal error, which is we go on to see the X-rays and MRI before we talk to the patient. So the dictum is listen to the patient. There is a very interesting study which was done long back, and we just in that we took 100 normal people without any back pain, and we did their MRIs. And out of that, almost 2/3 patients had abnormal discs, and more than 38% had abnormal disc at more than one level. So this is a thing that we have to keep in mind, that a lot of the asymptomatic people will also have abnormality in their MRIs. Then the next thing that we have to see is what is the pain syndrome that the patient is having. Is the patient having only axial back pain? Is there a referred leg pain? Or is there a neurogenic leg pain? So little bit in brief, how to differentiate between a referred pain and a radicular pain. In a referred pain, it's a non-dermatomal distribution. There is a deep dull aching pain. While in a radicular pain, there is a dermatomal distribution starting from the spine, going down till the leg, below the knees. A very common cause that we see for a referred leg pain is a physical arthropathy or SI joint involvement. So these pattern of pains are not going along a dermatome, and they are usually confined above the knee. So what are the differential diagnoses which you can make by a quick cursory examination? If the pain is getting if the pain of the back is getting worse with the flexion, it indicates that there is a discogenic problem. If the leg pain is worsening on flexion, it's a herniated disc. It is most commonly a herniated disc. If the extension of the spine is making it worse, it shows that there is a physical problem. And if the extension is if the leg pain is getting worse with extension, it shows that there is some sort of spinal stenosis. So the first common clinical scenario that I want to touch is lumbar disc collapse. So lumbar disc collapse is a clinical diagnosis. Patient will generally present after an episode of heavy weight lifting. A young gym-going person, he will come to the OPD with the leg pain, which is having a dermatomal pain distribution. It is associated with paresthesia or numbness, and patient will have on clinical examination a positive nerve stretch sign. The other presentation, which is often rare but missed, is a chordae equina syndrome, which you must be aware of. And in this, patient will present with a severe low back ache. There will be saddle anesthesia, motor weakness, and bladder bowel involvement of varying degree. So we have to keep this chordae equina syndrome in mind, and this clinical presentation requires urgent intervention. So if you look at a little bit of the anatomy, the most common presentation of a disc collapse is the posterolateral disc collapse. And when there is a posterolateral disc collapse, this blue circle, it will involve the traversing nerve root. While if the disc collapse is far towards laterally, it will involve the exiting nerve root. And once the nerve roots are involved, they will shoot down the pain down the leg in a particular dermatome. This is a typical scenario, but clinically we see that there is a lot of overlap. But still the pain would be going down the leg below the knee in a dermatome which is associated with the nerve root. So when you look at the natural history of disc collapse, 80% of disc collapse will improve in 6 weeks. 90% of them improves in 3 months. But there is a downside to avoiding surgery, which is that once we cross 3 months period and patient is avoiding surgery, the surgical rate decreases and the success of the surgery decreases down the line if we delay it too much, and it is associated with high degree of chronic back pain and lower return to work rates. So our aim for a disc collapse patient is see through the pain phase and see if there aren't any red flags associated, and we give them a non-operative treatment, which includes short period of bed rest, only 3 to 7 days, not prolonged. We give them pain management drugs. We can give epidural steroid blocks. We give them activity restriction. We give them rest, and the literature says that there is not much role of fraction or bend now. What is the timing of surgery that we should suggest? So this is basically a shared decision between the patient and the doctor. When there is acute cauda equina syndrome, we have to operate within 48 hours. Or when there is a significant motor weakness, then we have to operate early. And most common clinically, we see that when there is a failure to non-operative treatment, then we suggest surgery. In surgery, we have various options. We can be open surgery, we can advise a micro discectomy, tubular or endoscopic surgery. So as we go from top to down, we are getting a more minimally invasive option. We are decreasing the tissue handling, the muscle dissection, and obviously the incision size is decreasing. But the most important thing that we have to keep in mind that is the decision to take the surgery is the critical point rather than the size of the incision. Okay, the second clinical scenario that I want to touch is lumbar canal stenosis. So in this, we see that this ligamentum flavum is hypertrophied and this is compressing the canal. It's a very, very common clinical presentation. It is either simply this issue or it is associated with other problems like spondylolisthesis or scoliosis, or it can be isolated presentation of a lumbar canal stenosis. So in this clinical syndrome, it is commonly seen in elderly. There are lots of symptoms but very few signs that are visible. Patient will complain of gluteal or leg pain, plus minus back pain. They can be associated with neurology. And the pain pattern that the patient would complain is of a claudicate impact. So the patient would complain that after walking a certain distance, like so patient would be, typical patient of a lumbar canal stenosis will tell that when patient starts walking, they will feel that there is numbness and heaviness going down in both the legs, and then patient has to either stoop forward or sit down to relieve the symptoms for some time. And when the patient will start walking again, then the patient there will be recurrence of symptoms. So this is a typical presentation of a lumbar canal stenosis patient, and this cartwheel sign is a very famous sign that we use in spine surgery. That when the patient bends forward on a cartwheel, she is able to walk further. But we have to be very careful about certain clinical differentials of lumbar canal stenosis, which would include vascular claudication. So a basic difference between vascular claudication and a neurogenic claudication would be that patient would have relief of pain when patient stops walking in vascular claudication. While in a neurogenic claudication, patient has to sit down. Patient has to bend forward to increase the space in the canal. The other common clinical differential is peripheral neuropathy, which we have to keep in mind. And in this, patient would have a glove-stocking pattern of distribution of paresthesias more in the night time, and it will be unrelated to activity. It is commonly seen with vitamin B12 deficiency, diabetes, alcoholism, and the other differentials are the hip and knee and varicose vein. So when you look at the natural history of lumbar canal stenosis, we see that in long-term studies, a substantial proportion of patients do not deteriorate and they remain unchanged and are even improved by medical means. However, there is a downside to this. When the patient presents with severe symptoms at the baseline, we must suggest them surgery, because the long-term outcomes we have seen in many trials when we compare the conservative and the surgical treatment in these patients. Down the line, long-term benefit of surgery is more in terms of pain, function, satisfaction, and self-related progress. So what are the management options that we have? The non-operative management includes the medications, physiotherapy, exercise, pain injections. While in the surgical, we advise them laminotomy, which is decompression of the spinal canal, or when it is associated with other fusion surgery. The third clinical condition that I want to touch, which we see commonly in
Dr. Khanna, please try to finish in 5 minutes.
Yes, sir. Adult spondylolisthesis. So usually adult spondylolisthesis is a low grade, and it is associated, it is degenerative or light. In degenerative spondylolisthesis, there is listhesis of the spine one over the other. In the degenerative spondylolisthesis, it is usually seen in older females It is mostly low grade and at the L4, L5 level. And the pain distribution is here on the traversing nerve root due to the hypertrophic facet. While we are doing this clinical investigations for this, we can see that this facet joint has fluid and the one vertebra is slightly shifting on the dynamic X-rays. So this is the MRI findings. The other kind of variety is the lytic spondylolisthesis. This is mostly developmental and this is due to the pars defect. And it is either low grade or high grade, but it is mostly at the L5 S1 level. And here the pain is because of the compression of the exiting nerve. Lastly, we see the symptoms will be low back ache, leg pain, either radicular or claudicated type, and will be more in the extension. But the important thing that we have to understand is that the severity of back pain is not directly related to the degree of slip. So a patient with a higher slip might be symptom-free, while a lower grade of degree might be symptomatic. Again, the natural history in this condition, it is usually, there is little progression only up to 30%, and there is no clinical correlation between the clinical symptoms and slip progression. 75% of the patients who are neurologically intact do not deteriorate with time. And the indication of surgery here are again the back pain or leg pain which is not responding to conservative treatment, either if there is a neurodeficit or if there is a slip progression. In children and adolescents, the progression is much more common and there is a higher degree of slip that needs surgical intervention. One important thing that we have to understand is the patients who have more leg pain than the back pain are a good candidate of surgery, rather than this subset of patients who have more back pain or very low leg pain. Surgical options in this condition is again fusion, which are of various forms, again open or MIS. In summary, low back pain is a very common condition associated with high disability. For clinicians, it is vital to understand that the symptomatology and detailed clinical examination before going to the investigations. Most common clinical conditions have a steady natural history until they progress. And the physician must be able to identify the red flags associated with back pain, and early intervention in suitable cases leads to long-term good outcomes. Thank you.
Thank you, Dr. Khanna. Please, will you join us? Yeah, the house is open for questions and yes.
Yeah, Hitesh, it was a nice talk. I think you need to also explain to common clinicians here the cost of surgery, because I think they will be motivating the patient to send to you for scoliosis correction, but they should know a relative cost indication, because the implant itself is a costly affair. So that is one thing which you need to clear them up.
So you rightly pointed out, scoliosis is a very costly surgery because of the extent of surgery, ICU stay, hospital stay, and the implant, because a lot of implant is used. But all over the world, these surgeries mostly happen with patients and not others. Usually the cost of surgery can vary from 5 lakhs, at Artemis it varies from 5 lakhs to somewhere around 15 lakhs, depending on the complexity of the surgery. But as I told that most of the patients, a lot of patients are not able to afford, and we try to help them out by getting them in touch with multiple organizations. Again, if we are able to catch scoliosis early, we treat them at an earlier stage, the cost is very less. We manage them within 5 lakhs. But once it gets complex, of course, with the complexity of the surgery, the hospital stay, blood loss, everything keeps on increasing, and then that makes it very costly.
Other thing, I think you need to also tell that congenital issues, it might be still growing in spite of your fixation.
Yeah.
So that's another issue which you need to clear.
Actually, time was running out. Congenital scoliosis. Congenital scoliosis is basically when the vertebrae are not formed normally, and it happens due to some intrauterine insult, and they are associated with, because intrauterine insult, when it happens at the same time when spine is growing, our spinal cord is also forming at the same time, heart is also forming at the same time, kidneys are also forming at the same time. A lot of these patients have congenital heart disease. A lot of these patients will have undescended testes or one kidney, and they have there are 5 spinal cord anomalies associated with it. which can be tethered cord, syringomyelia, there can be a Chiari malformation, or there can be diplomyelia, diastomatomyelia, and actually we handle them before. So we always get neurosurgeons help before doing the scoliosis surgery. So if there is any congenital scoliosis, we look at the MRI. If there is any anomaly, spinal cord anomaly associated with it, first the neurosurgeon operates, releases the spinal cord, and then we correct the scoliosis.
Thanks a lot.
So my question is to both of you. I'm a medical oncologist. Spine में ना, whenever we ask for MRI spine, there are at least 12 to 15 findings, but impression is not written. So many times, and you wonder कि भाई L1 L2 में भी problem है, L3 L4 में भी है, हल्का सा disvesication तो सब में लिखा हुआ है. And you wonder, what am I supposed to do with this? There are some metastasis, they will write that suggestive of metastasis. But when they don't write impression, and that is a time there are 7 to 8 bold sentences, and you really don't know what to do. So when do we send to spine surgeon during this time?
Yes, so I think Dr. Varun may like to answer, but you're right, and I think this is because spine, as I was telling you, more of a clinical problem. And I think you throw light on that.
So basically, the word is clinical correlation. Until there is a clinical correlation with the MRI finding, we won't take it, it won't be of any significance. So if there is a clinical radiological match, that is the time. Or if there is an associated red flag that we can find in the back pain.
What are those red flags?
So sir, the red flags are basically a back pain patient coming to the OPD, who is
Back then, इसको नहीं.
सबको है, लेकिन उसमें if there is associated history of tumor or a malignancy, if there is fever, if there is advanced age, if there is a history of trauma. So in those events, these are the red flags that we have to identify. Very good.
Okay. Paresthesias and these things are also very common.
Yes, sir.
I would just like to add, so basically we classify spinal problem into three. One is malignancy, as you pointed out. So if there is any malignancy and patient is having back pain, that becomes a red flag, and it's a trauma. I think you are asking with respect to degenerative condition. If someone is having back pain and it is not getting better, back pain is basically has to be managed by a primary physician. Once it doesn't get better after 3 months of physiotherapy, and the pain is significantly affecting the quality of life, or if there is associated radicular pain, which is going down one particular downward pattern and it is not getting break of physiotherapy, or there is a neurological deficit that the patient is having a foot drop, EHL weakness, hyposthesia, or if there is a bowel blood involvement, these are the conditions when we should send to the spine specialist. Otherwise physiotherapy, almost we should try physiotherapy and medicines.
I think I would like to add that, as you just said, the back pain which is not able to relieve even by conservative measures, then even when you investigate and nothing has been found, probably the most common nowadays is the postural issue. So everybody has to look for the postural issue and then probably look for the, as you said, physiotherapy and strengthening of the back. And then you can go for any kind of other treatment.
Yeah. I think a lovely lecture as well. I think the clinical approach behind both of you, and I think the EHL word, I think as primary care physicians, we all need to understand that most commonly it's the L5S1 test modality which we all can encounter, and very easily we can test the EHL weakness. So I think that's the first thing we all as clinicians should know before we get to order an X-ray or an MRI. In the era of the MRI, there was a study done by, I think, JAMA, many studies, that 70% of the general population has some kind of a PIV. But does that match the symptoms is much more important. And the people. And we should never treat the MRI, we should treat the patient. Point number one. Point number two, there is a role of EMG, NCV also in all of that. When we do paraspinal electromyography to know, if there is, denervation. But it has to be in the hands of clinicians versus the technicians, and I think there's a gray zone on it. Therefore, the orthopedician, the neurosurgeons all get kind of debated. Symptoms are matching, electromyography is showing something else. So I think the patient is the priority. I think a lovely lecture, just the word on EHL and the electromyography.
So basically now even a common phenomenon now in movement can cause foot drop and EHL weakness. How do we differentiate whether it is coming from the spinal to some peripheral neuropathy or any injury to the peripheral nerve? So there is where I think EMG and CG comes into play. So if there is a denervation of paraspinal muscles and there is a F wave and all those, so an expert technician, neurophysiologist, neurologist can tell whether the lesion is pre-ganglionic or post-ganglionic. So if the lesion is pre-ganglionic, then of course it's coming from the spine. But in my practice, I compare EMG and CG in every case. It is only when I have someone is having diabetes or someone is I feel that there is a glove and stocking pattern neuropathy, or I feel that the dermatological pattern is not pattern. Like if someone is having EHL weakness and EHL is the greater toe, the greater toe is not going up. And along with that, there is a hip abductor weakness. So that is a Z5 abductor. But if someone's hip abductors are good enough, it is isolated EHL and just trauma to the knee, then maybe there is a common coronal nerve injury. So in those cases, we would like to differentiate. And sometimes there is a very common condition called flexopathy, singularly brachii flexopathy. And I've seen patients coming with acute weakness in the hand just after viral infection, very severe pain. The patient has been recommended surgery. And we see that there's not that much of compression. But sometimes we see them and we find that there's not much of compression. And maybe this patient is having brachii flexopathy because of some viral infection and gets treated with by a neurologist. So I think clinical diagnosis in spine is very, very important.
I have got a question for both of you. As you put in instrumentation, anything, magnetic or when is this is to be removed? Will you remove it or it will remain stored in his or her?
So instrumentation basically in spine, in the spine basically the first is decompression, you remove the pressure over the nerve. The second is instrumentation. Instrumentation is just an aid to achieve spinal fusion in proper alignment. So now there is a concept that we should fuse the spine in proper alignment. Once the spine fuses in that alignment, we can move the instrumentation in normal degenerative conditions. So if we have fused L4, L5 and it fuses in 3 to 6 months, but we wait till 2 years, and after 2 years the instrumentation can be removed, like in any orthopedic surgery of the band fuses. But as such, there is no need to remove it, unless until there are really 1% of the patients who are psychologically bothered and have something inside. Otherwise, there is absolutely no need. But in scoliosis, we never remove the instrumentation. Even after the spine fuses, once we remove the instrumentation, we have seen that even the fused spine, by its original genetic nature, keeps on getting worse slowly. So in scoliosis, we never recommend that the instrumentation should be removed, even after the spinal fusion has been achieved.
That means it's a lifetime.
Better. But even after removing spinal instrumentation, we are not achieving anything. Spine is fused. It is some patients, the patient believes that once we remove the instrumentation, patient spine will start moving. It doesn't happen. The spine is fused. That was the whole purpose of the instrumentation. Maybe you would like to add something.
Dr. Hitesh and Dr. Varun, wonderful presentation by both of you. Many people are asking, are you doing the same kind of work or are you doing a different work and Dr. Hitesh is doing a different work? So many people are confused actually. Can you just explain?
No, basically, spine, so this is very interesting. So now recently a lot of studies have proven that the success rate of spine surgery increases tremendously if there are two spine surgeons operating together. And there are proper studies in US, a lot of centers have changed their practice where two surgeons operate and we are following their practice in our case. So in our cases always there are two spine surgeons. And basically both of us right now, we have 4 actually consultants in Artemis. All 4 of us are doing all kinds of spine surgeries. But deformity is sort of my passion, my forte, so I take it a little bit further and do a lot of complex deformities. But these guys help me a lot in all that. And then we keep exchanging information and all that. And spine is a big field. All these guys, I think they are trying to subspecialize in one particular field.
So I'm more inclined towards the minimally invasive surgeries, which would be like the ones which are using tubular retractors or endoscopes. So endoscopic spine surgeries. So I am more inclined towards that. So together we are like covering all the possible things under the umbrella for spine surgery.
Some people at the back were asking if we refer a case of prolapsed intervertebral disc. Do you accept that?
Yeah. That is 80% of our cases. That's still there.
Okay.
My cases.
All right. What is the probable cost of dealing with a prolapsed intervertebral disc in your setup?
So in our setup, basically, as if you do only decompression, which can be the endoscopic or microscopic, the cost is around 1.5 to 2 lakhs. If we do fusion, open fusion costs around 3 lakhs, and a minimally invasive fusion for one level around 3.5 to 4 lakhs.
Are you also doing the cementing thing?
Yes, kyphoplasty.
How much does that cost?
So kyphoplasty we can do anywhere from 1 lakh to 4 lakhs. The reason is with 1 lakh we just put in the cannula, put the cement known as vertebroplasty. But if we do kyphoplasty, where we have used a kit, where we put a balloon and inflate the balloon to achieve the normal shape of the vertebra, that with that kit it comes to around 2.5 to 3 lakhs. And now there are even further implants. These kits are supposed to be disposable. That is something which everyone should know. We should never reuse them. So they have to use only once.
Right. What we understood from your talk was that we have two great gentlemen here who are doing great work on spine.
Thank you.
And we have two great academic pillars of the forum, Dr. Tulsi sir and Dr. Kalra sir, to ask you some great questions.
Thank you, Dr. Varun. No great questions, very simple questions. Wonderful talk by both Dr. Hitesh Garg as well as Dr. Varun Khanna. Varun Khanna is from my university, the Kolkata University. Pleasure to have you, sir. So, Dr. Hitesh, adult scoliosis is different from the childhood scoliosis in the sense that this is basically a degenerative scoliosis. So, probably the treatment may be different, more conservative here. At least 90% of the people or the patients probably adult scoliosis would be conservative.
Yeah, I just touched because of the shortage of time. Adult scoliosis, just one slide.
Yeah.
You're absolutely right. Adult scoliosis is a totally different ballgame from childhood scoliosis. Number one, most of the cases are conservative. We try to look at the quality of life, and it is not scoliosis. It's actually the lateral, the sagittal profile. When the sagittal profile is normal, even with I have seen 70 degrees of scoliosis, a lot of patients are not that much affected, and you don't like to touch them. Only the quality of life is significantly disturbed or the patient is getting neurological deficit.
So, compression of the neural elements probably
yes.
Deep surgery.
True, yes. But whenever we do decompress in scoliosis, we like to crack the alignment. Another thing is if the sagittal profile is disturbed, there is a syndrome known as flat back syndrome. So if we use the lumbar lordosis, the spine gets straight, the patient, the center of gravity falls forward. Those are the cases where the patient cannot walk even 50 yards. Sometimes we have to crack the scoliosis, but crack the alignment of the spine. And a lot of these surgeries now are doing in minimally invasive manner. We don't like to open in adult scoliosis. That is another thing. We like to do minimally invasive. We change the discs with gauges through the front, from the side, known as olive surgery, oblique ligament aortic fusion. And then we do percutaneous fixation from the back with microscopic decompression wherever it is needed.
Great, sir. Dr. Varun Khanna, vertebral compression fractures are the most common complications of osteoporosis and osteopenia as well, especially in frail elderly people. So, would you like to do some vertebral augmentation here, like kyphoplasty or vertebroplasty, or even a plate made of titanium vertebroplasty probably? What do you do, sir?
So basically, vertebral compression fracture, it's very common issue
in osteoporotic patients.
Osteoporotic spines, which is very common in our Indian scenario. And the indication for a surgery. So most of the good thing is that most of these fractures go on to heal up to 60% of time, and we just have to protect the spine from getting further compressed. We have to give them a brace, we have to give them analgesics, we have to give them osteoporotic treatment.
So conservative treatment, right?
Until it is not improving and the pain is still persistent at 6 weeks, patient is not able to get up, patient is not able to turn in the bed. Those are the times when we will see the comorbidities and give them a suitable surgery.
So when you do a vertebral augmentation, are you not worried about, the adjacent vertebra?
100%, sir. That is a very common complication of this vertebroplasty. We fix one, it becomes hard, the cement is hard, and the other bones are still soft. So we have to address anti-osteoporotic measurements along with the surgery.
But that would take time.
That would take time. So
As we know, established osteoporosis cannot be reversed.
Yes.
Probably progression of this can be arrested.
Yes.
So for that, especially in GIOP, that is glucocorticoid-induced osteoporosis, what would you prefer? Do you prefer a bisphosphonate, or would you prefer, any other drug like denosumab or tetrabenazine?
Yes. So basically we have to see the renal profile of the patient. If the renal profile is okay, then we can go on to give the drugs like
I'm talking about GIOP.
glucocorticoid induced. So sir, in those cases,
Denosumab probably the drug of choice.
yes.
Probably bisphosphonates don't have much of effect, so denosumab.
Yes. So we give that 6 monthly.
Yeah.
And we continue it. And if there is an urgent requirement, if there is a very steep osteoporosis, then we can add teriparatide along with denosumab. That has been shown to have maximum increase in the DEXA scan values.
Also used in multiple myeloma and bone metastasis. Denosumab, but this is a contraindication for giving teriparatide.
Yes, sir.
Thank you, sir. Thank you, sir.
Maybe I'm the last part of the guard. Sir.
The guard.
Sir, if you remember name Ashtabakra. Ashtabakra. Ashtabakra was a great saint. He was Kul Guru of Janak, Badullah of Ram, Lord Ram. जो अयोध्या में जिनका he was having deformity at 8 angles involving 4 at spine level. मैं ये जानना चाहता हूँ क्या अष्टावक्र आज के जमाने में होते कि आप उसको ठीक कर सकते थे? And what would they cost? 8 deformities. Ashtabakra means 8 जगह पे उनकी deformities थी, and he was a great knowledgeable person, the best known to Indian mythology till now.
What about the degree? What was the degree?
More than 50 degree at the spine.
In my opinion,
Spinal fusion.
yes, I think with the technology that we have these days, I did not go in the technology.
So I am sure you may not be well prepared for this topic, mythology. Just my parallel questions are, first is about posture correction. It was, मैं इसको बाद में बात करूँगा सर, अभी मैं सोचता हूँ कि लोगों को घर जाना है. So posture correction, is it a part of or is it a additional to your therapy?
Yeah, exactly. So a lot of patients, as our neurosurgeon friend was telling, come to us with postural problems these days. These problems are managed by the physiotherapist. We refer them to the physiotherapist to work on the muscles to build the posture. It happened with me, it happened with our surgeons because we are in a very long posture most of the time.
तो मेरे लास्ट 2 कमेंट्स हैं. अभी किसी ने बात चली थी कि MRI में उसमें ये मिल गया वो मिल गया. मेरे को भी रोज मिलती हैं. CPC में 15 चीजें मिल जाती हैं. कोई कहता है ये ठीक नहीं है वो ठीक नहीं है. तो मैं ये कहना चाहता हूँ कि कभी किसी को मुकम्मल जहाँ नहीं मिलता तो सबकी एग्जैक्ट जो परफेक्ट एमआरआई और सीपीसी या कोई भी रिपोर्ट मिले जरूरी नहीं है। माई एक्सटेंशन टू दी सुपर स्पेशलाइजेशन, हम तो भी कहते थे, सोचते थे कि शायद एक जमाना आएगा जब लेफ्ट हैंड का और राइट हैंड का सर्जन अलग होगा। तो क्या आपका राइट और लेफ्ट साइड का स्पाइन सर्जन अलग है क्या?
He's joking, sir. He's joking.
यहीं से शुरू होती है इमेजिनेशन। ये राइट और लेफ्ट साइड का स्पाइन सर्जन, राइट साइड एंड लेफ्ट साइड, राइट आई लेफ्ट आई। So if it is so,
two spine surgeons operating, one operates on the right side, one operates on the left side.
सर आजकल हिमेटोलॉजिस्ट जो है ना वो आरबीसी के अलग, प्लेटलेट के अलग हो गए हैं।
I think wonderfully ended by Dr. Varun Khanna sir, and as I promised 10:25 we have finished the question and answer session. So we are on target to be at home by 11 o'clock. I am so grateful to all of you to be here on the Diwali. My heartiest wishes to all of you for a very happy, prosperous, and as I said, a happy Diwali in mind. Please remember, happiness is a state of mind. I would request Dr. R.K. Wadhwa, my friend, my philosopher, my darling, and my guide to summarize the CME for us.
Thank you, Sushil. One very small last question. What do you do with hemivertebra, Dr. Garg?
So hemivertebra, first we have to document hemivertebra hemiincarcerated in not always the progression of scoliosis. So first we have to document that it is actually causing progression of scoliosis. If the scoliosis is not getting worse because of hemivertebra, we do that's the first thing. Second, if the scoliosis is getting worse, the best stage to operate is 3 to 4 if it is a single hemivertebra. We remove that just for short fusion, patient is fine. Or at least as soon as we get to know about it. Once the patient enters the puberty and there is a sudden progression of scoliosis, in that cases we cannot do small surgery in a short one of the cases. We have to do full scoliosis because now the whole of scoliosis.
I just want to ask Dr. Hitesh Garg and Dr. Varun Khanna, do you only see patients in Artemis or you have your own clinics?
I have my own clinic, but that is more mainly to decompress at Artemis because the Artemis rush was increasing too much and waiting time is too much, so I started my own clinic for 3 days a week. I do on Tuesday, Thursday, Saturday in Arcadia when I go to Artemis. But otherwise I am in Artemis from 8 o'clock in the morning till around 6, 7 in the evening.
Dr. Varun Khanna, do you have your own clinic also in renal cases?
Sir, right now I'm only working at Artemis Light, New Friends Colony, other than Artemis Gurgaon. So I'm there at Monday and Friday, Monday and Saturday, morning 10 to 12. Monday, Saturday 10 to 12, Artemis Light, and the rest of the time I'm
Wonderful presentation by our two honorable speakers, wonderful moderation by Dr. R.K. Wadhwa. सर अगर कभी कोई गरीब आदमी, गरीब पेशेंट हो तो कोई कंसिडरेशन है क्या?